And with that, we'll move on to our topic of today, which is self-advocacy to action. Our presenters are Zoe Peach, who is prevention team lead here at Caracole, Ariel Shaw, who is a health educator here at Caracole in our Ending the Epidemic team, and then myself, Adam Riley. So with that, I'm going to pass it over to Zoe for her to go into her part about self-advocacy to action.
All right. Thanks so much, everyone, and good afternoon, everybody. So I'm going to be tackling the first part of today's webinar, focusing on self-advocacy. So our objectives throughout the presentation today, through our three presentations that we will be doing, we'll start off with describe the three types of advocacy and advocate, understand how social determinants of health impacts one's ability to self-advocate. Ariel will be going over legal rights and different recourses for folks living with HIV, and in general rights of folks in healthcare settings. And then finally, Adam will talk about exploring effective strategies for advocating to lawmakers and public policy officials from a new perspective. All right, we just have a couple more of the introduction slides. So we'll start off just talking about different forms of self-advocacy and then delving more into what it looks like in medical settings. So first, I want to review the different types of advocacy and advocates that we see. So there are three kind of groupings that we're going to be using as a conceptual guide to get us through this presentation today. One is being self-advocacy, which is the ability to understand and effectively communicate one's needs to other individuals without compromising the dignity of oneself or others. So that's going to be what I'm going to be focusing on today, which is, I'll say, is a challenge for me as working in this field. Sometimes it's a challenge to advocate for myself because I am used to doing peer advocacy, as many of you that are on the webinar today are also used to doing. Peer advocacy is taking action to represent the rights and interests of someone other than yourself. So grouped in this would include medical advocacy for one of your clients, one of your patients, for medical folks, a participant, something like that. And then finally, Adam is going to be talking a little bit more about group advocacy, which is taking action to influence social, political, and economic systems to bring about change for entire groups of people. So this could refer to things like awareness events and lobbying days, things along those lines. So first, I want to do a brief history of where self-advocacy has came from. And I do also want to point out that Adam has dropped several links in the chat about some group advocacy organizations, and you're more than welcome to visit some of these links throughout the webinar to see some more details about our partner organizations. So self-advocacy, this entire concept, is originally rooted in the disability rights movement, especially in the late 1960s, in tandem with several other civil rights and liberation movements. Specifically, this concept was among people with intellectual and developmental disabilities. This was in a significant contrast to the traditional caretaker-led models, in which case the caretaker would decide what is best for somebody. Under the self-advocacy model, it was rooted that folks could decide what was best for them, what the path forward for them was, and what treatment modalities they seek to explore. In the 1980s, this idea really took hold in healthcare. And this came about from a couple of different concepts. One of them being cancer survivorship, which more generally refers to folks that are living with cancer and the advocacy that they do for themselves during that time period that they're living with cancer. Hence the focus on that word survivorship that has been a strong tradition in the cancer space. And also self-advocacy in a little bit of a different form also came in the early days of the AIDS pandemic. In the AIDS pandemic, it looked a little bit differently. I'm thinking here and conceptualizing here with groups like ACT UP and the Treatment Action Group. So the Treatment Action Group specifically kind of split off from ACT UP. It was a subcommittee of ACT UP originally, and then they ended up splitting off from ACT UP to specifically focus on HIV treatment and HIV research. This concept was relatively new. that patients would be involved directly in the research. And those early days of ACT UP and the treatment action group have led to a lot of the research ethics protections and community advisory boards that we see today. From my own personal experience, just to add to this a little bit, I currently serve on the community advisory board to what used to be known as the AIDS Clinical Trial Group at the University of Cincinnati. They've recently changed their name. It's now the Adult Clinical Trials Group for HIV and other infectious diseases. Quite a mouthful, I must say, but that was part of the destigmatizing movement, for one thing, to get away from using AIDS in the name and to also reflect their broader mission. I also served in my own private life as part of the University of Cincinnati Research Participant Advisory Committee. So a lot of this concept of patients and participants being involved directly in research ethics came out of what ACT UP, the Treatment Action Group, and many of those other organizations did in the early days of the AIDS pandemic. But with all of that said, who you are impacts advocacy. We all know that there are significant disparities among healthcare outcomes for marginalized groups. For one thing, with folks with a different spoken language from their healthcare provider, that makes it incredibly difficult to advocate for yourself. If you're advocating through a medical translator, that makes it quite difficult. So here's just a couple of the statistics. 49% in a survey reported that they had trouble understanding a medical situation. 2/3 faced some kind of a barrier in accessing healthcare. And 20%, and I think this is the most frightening statistic of all, did not seek healthcare services if these were not readily available out of the fear of not understanding their healthcare provider. I think one of the biggest pieces of self-advocacy in a healthcare setting that I'll be talking about is researching your own condition, making sure that you have lists of questions prepared for your provider, and overall being able to keep up with your provider to a certain extent to understand the condition. So the evidence of lessened self-advocacy among racial and ethnic minority-based people can be attributed to several different factors. There are differences in role expectations. So there is, I noticed this among our folks living with HIV. I would say this is from my own personal experience. I don't have any specific research to back this up. I would say a lot of our older folks living with HIV are very strong believers that whatever my doctor says is best. And I'm just going to go with what they say. I'm not going to challenge them. Whatever they say is going to be best for me. There is this concept of folks feeling disengagement due to feeling stereotypes in the healthcare setting. There's also, for some folks, a lack of opportunities to participate. One of the things that I think is an excellent tool for self-advocacy are commercial apps like MyChart, since that gives you an opportunity to view the notes about your care and to view your test results directly. And if you don't have access to a smartphone, if you don't have access to the internet, you don't have access to apps like MyChart in order to view that system. There is also, as we've kind of discussed all week, there is still substantial and unfortunately well-founded mistrust of the medical system. As many of you know, there's significant disparities in maternal health outcomes for people of color. There's significant historical disparities when we think, as we talked about yesterday, Tuskegee and other dark studies of the past, including here in Cincinnati, the infamous Cincinnati radiation experiments, which I'll put a link in the chat about the Cincinnati radiation experiments here when we shift over to Ariel, since that's one of the main impetus for the Research Ethics Committee over at the University of Cincinnati to now exist. All right, so now I'm going to talk about a little bit more structural barriers. Pardon me, I forgot the order of my slides. One more thing about structural barriers, and then we'll move on to a couple of easy things to remember when we're thinking about self-advocacy in the healthcare settings. So this survey is a little bit old. It's from the 2015 US Trans Survey. We can hope that things have gotten better since then, but given the current legislative environment, unfortunately, I doubt that it has. So, 1/3 of trans people who saw a healthcare provider in the past year reported having at least one negative experience related to being trans. There's also some statistics that, thankfully, they're much smaller, but around 7% of trans people reported some kind of an assault in a healthcare setting. As far as geography goes, I have seen this unfortunately play out heavily in my own life. The federal government does project a shortage of over 20,000 primary care physicians in rural areas by 2025. And I see that play out in my own life since I'm originally from a rural small town, and much of my family still lives in these rural areas. So, my family recently, specifically my mother, has been having a lot of significant healthcare challenges over the past couple of years. I have access here in Cincinnati when I had some significant healthcare challenges 3 years ago. I have access to an academic medical center. My primary care physician, for any strange finding on my tests, she was able to refer me to different specialists and even subspecialists that were able to work up my condition and look into some of the possible causes of what was happening to me. For my mother in a rural area in central Kentucky, she has to go at least an hour. And for many folks in eastern Kentucky, it's several hours into Lexington, where the nearest academic medical center is. And academic medical centers are a source, for me at least, call me a little bit biased. I absolutely am, since, again, I am part of the UC Research Participant Advisory Committee. Academic healthcare systems are a beacon of hope for folks with rare diseases. So that way folks are able to get enrolled into different research studies, and they're able to see different specialists and subspecialists. So when you live in a rural area, it's difficult to have access to that new groundbreaking research and those research studies. We also know, as I kind of mentioned on the last slide, that people of color, specifically Black and Latino people, receive significantly lower quality care compared to white people, even after insurance coverage and income have been adjusted for. And if we wouldn't adjust for insurance coverage and income, I fear that those statistics would even be worse. All right, so there are 5 basic steps that I'd like to say are excellent for self-advocacy in healthcare. For those of you that are healthcare providers, this is something to keep in mind, that your physicians, that your patients may be looking for these things from you. And for those of you that are social workers and case managers, and even someone with a loved one who is experiencing some difficulties in the healthcare system, these are 5 easy steps for you to remember as well. So for the first thing, identify what you want and what you need from your appointment and communicate that with your physician. Again, a fantastic way to do that is through an app like MyChart. So that way you have a record of what messages you've sent, you can prepare questions ahead of time, and other things like that. A sub-bullet of this, I would say, is physically writing down your questions. That's an excellent way to make sure that you get your questions answered and that you're prepared before you go into an appointment. And on that note, come prepared. Before your appointment, do your research about your treatment and or your condition. There are numerous websites that you can find high-quality information, from the National Institutes of Health to the Mayo Clinic, Cleveland Clinic. Places like that have wonderful information about different treatment modalities and different conditions. Number 3, this tails right along with what I was saying about the MyChart app. Keep a copy of your medical records, treatment logs, and progress for your own reference. For me personally, it was powerful to see different charts of my lab results over time to see if things were getting better or worse. I trust that my physician monitors that as well, but it's good for me to know and be able to ask questions for my physician. Should this be going up? Should this be going down? Number 4, never be afraid to get a second opinion. As Ariel will talk about here in a moment, you are enshrined different rights by law to get second opinions and to reach out for additional advice about your healthcare. And number 5, reach out to those around you and build your support system. So I've seen, again, from my personal life over the past couple of years with taking care of my mother, my brother and I have done a lot of research into her conditions and into her symptoms before we had an answer to what was going on. And we've been able to take this to her primary care physician, and we've been able to advocate for her to see different specialists. So, with that said, I am going to turn things over to Ariel to talk a little bit more about what of these rights are enshrined in law and what that looks like.
Thank you so much for that, Zoe. And as Zoe mentioned, she talked a lot about self-advocacy, and part of self-advocacy is knowing what your rights are as a patient whenever you find yourself in a hospital setting. And so it is really, really important to know that you legally have the right to care. You have the right to know who your providers are, to engage in your own care. Because and there is a very, very big fear among folks who are living with HIV of discrimination, particularly from healthcare providers. And so in that regard, you have the same rights as everyone else when it comes to healthcare, doctors reviewing your records, as well as feeling if you need to be transferred to a different doctor because you feel like that the care you're getting at this particular hospital isn't being respected. Next slide, please. And so with that being said, Ohio is one of 32 states that criminalizes HIV. And essentially what this means is that if you are living with HIV and you do not disclose your status while engaging in sexual relations, then that can be considered to be a second-degree felony. And many of these criminalization laws affect those who are pushed most to the margins, such as Black and Brown folks who are living with HIV. And something else worth noting too, as well, is that these laws disadvantage people who are living with HIV because the fact that they can be used to silence those who are living with HIV, because of the fact that people in power can use these laws to enact harm on folks. And so we have hope for the future that we can get these criminalization laws reversed. Next slide, please. And so in the state of Ohio specifically, Ohioans can be charged with second-degree felonious assault, and it can also be placed in prison if they do not disclose their HIV status to their partners. And furthermore, they're also required to register as a sex offender. And on the last slide, I mentioned that individuals can have their status used against them. And an example of this is someone who has a partner who is abusive, and this abusive partner says, "Well, if you leave, then I'm going to use your status and say, oh, you gave me HIV." And so, just in that very example, we can see how these laws negatively impact people who are living with HIV. And beyond that, penalties for people who are living with HIV can sometimes be 2 to 29 times longer than those who are not living with HIV. And this doesn't even include the possible fines that can be associated with these penalties as well. And so I think a really, really good question to ask ourselves is, who is this law? Who are these laws benefiting? And next slide, please. And regarding law enforcement, if you are living with HIV and if you find yourself having to engage with the law enforcement, like the police, you are only required to provide your name, address, and date of birth. And remember to record any and all interactions that you may have, and you are allowed to request name, badge number, etc. From officers. And then it's also important to know that you also have a right to an attorney, and you are not required to provide your HIV status if you do not feel comfortable, nor are you required to consent to any sort of medical testing. And so with that, it is really, really important to remember that you have rights, and that self-advocacy is so, so, so important. Next slide. And regarding the workplace, you are not required to disclose your HIV status, and places of employment are not allowed to ask if you are living with HIV, and nor can you be fired from a place of employment because of your HIV status. And as the slide mentions, the only time employers can ask medical questions is when they are engaging in affirmative actions for those who are living with disabilities, as well as if you are asking for a reasonable accommodation of some kind. And if you feel like your rights have been violated in any capacity, please know you can contact the Equal Employment Opportunity Commission, and they would be your next step in terms of what to do if you feel like you've experienced any form of just employment-based discrimination. Next slide. All right, and regarding people living with HIV, in 1973, the Rehabilitation Act got passed, and essentially what this means that people who are living with HIV are protected from discrimination based on their status. And if you feel like you've been discriminated against due to your status, you can file a complaint with the U.S. Department of Health and Human Services Office for Civil Rights. And next slide, please. Oh, and next we'll be going with Adam to touch on policy and advocacy.
Thanks, Ariel. And just to let everybody know, some of those links that were put in the chat, the places that Ariel just talked about where you can get file a complaint with for employment-based discrimination, that kind of stuff, those have been shared in the chat, links to those. So I am going to go through a larger look at advocacy and how advocacy can be turned into action and policy change. So next slide, please. So one thing that we have to keep in mind when we are advocating for change in especially in our society in the United States, is that we live in a reactionary society, not a proactive society. So that is something to really, in my opinion, keep in mind so that you're operating within the reality that our society operates in. So there's a few different reasons why it's hard to engage the larger community in advocacy. And there's some of these are the reasons why. And these are just kind of normal human tendencies that people have. So there's the normalcy bias, which is a human tendency for people to not account for changing conditions in the future. So people think if things are working the way that they are now, that's the way they're always going to work and nothing's really going to change, even though we know that change is constant. But that is definitely a bias that a lot of people have, especially when it comes around policy change. Another thing that's affecting this reactionary versus proactive is delaying discounting, which is an idea of taking less now rather than waiting on a bigger payout later. So we live in a society that is very much not only reactionary, but wants to have immediate gratification when things happen. And unfortunately, when we're talking about policy change, none of that is immediate. It is a long process that one has to go through to actually get that policy change done. And a lot of times in the end of it, you're not getting everything that you wanted because it's pretty rare that there's sweeping policy change that happens in the United States. Most change that happens is incremental and over time. And then there's the idea of declinism, which is an unmotivating belief that the future is dark compared to a rosy past. So that whole idea that somebody could go back in the past and society was better somehow than it is now, which we all know is a falsehood, but that's what this is kind of getting at, is that somehow the past or the present is fine, but the future is dark. And if people have that kind of view, that's not only is it an unmotivating belief and view, but it's one that is going to actively work against somebody wanting to even see change because they look at the future as so dark that it's too much to bite off to make these changes. And so because it seems too much, too big, too daunting, people just kind of give up and they don't know what to do. So they stay in this declinism type view or belief of things. And then there is a pervasive view out there that societal problems are caused by individual choices. That whole idea that you can pull yourself up from the bootstraps or whatever that saying is, kind of gets at this, that it's very individualistic, which American society has always been a very individualistic society, and it will continue to be so. But when we talk about policy change, obviously an individual cannot make policy change. It takes an entire group of people to do that. Somebody doesn't just get to write it up and then it's done with. You have to involve, depending on what level you're working at, you might have to involve a mayor, city council, county commissioners, other elected officials, other appointed officials. Maybe you're dealing with the school board. And then when you get into the state or federal level, you're dealing with senators, representatives, people who may or may not hold the view that community level change needs to happen as well. So I just point that out because I feel like over time, that's been a real issue in getting people to see that no, societal problems, sure, they impact the individual, and individuals do make choices, but the choices that they're left with are because of the community level, how the community has decided that society is going to work. You've given people, if maybe you change the policy, people might have an entire buffet of options when it comes to making a choice on X topic or X thing in their life. But because of how our society is set up, guardrails, you might call them, or just, put in place laws and regulations, that then lowers choices, and you might not have an entire buffet of choices to go from. And you might only be left with maybe one or two choices, and they're not all great. And one thing that's not on this slide that I think is another thing to keep in mind, that because when you're talking about group advocacy and policy change, with a lot of these kinds of things, you're going to run into those not in my backyard kind of people, the NIMBYs. So I just say that to put that out there, because in my experience, just about anything that you're advocating for, there's going to be at least one person, if not a handful of people that fall into that category that you're going to have to try to engage with and hopefully get them to see your point of view as well, which can be very powerful. If you can get people who are on that side in the beginning, to change their mind, that goes a long way with other people in the community who might have held those same views. Next slide, please. So, talking about engaging with the future is what I'm calling this, and the reason I'm calling it that is because to advocate for true policy change, one must connect today's actions with tomorrow's consequences. What we do today is impacting tomorrow. So every time we're making decisions, we are engaging with the future, whether that's our individual future or larger futures. So getting people to kind of see that also goes with that incremental change as well, that you might be working towards a larger goal over time, and you might only get one little piece of it done. That means you have to keep going back at it. I think a good example of really looking at today's actions to have an impact on tomorrow's consequences is in the field of early childhood development. In 2003, that field adopted what is called the active metaphorical language of building brains. And that's a real mouthful, but basically the goal around this model is to reduce childhood poverty, abuse, neglect, and increase housing stability through highlighting the long-term value of positive relationships, supports, and experiences during the earliest years of life. So that sounds like a really lofty goal, but since its adoption, there are some communities that have widely adopted this, and they have actually seen this model have the impact that it was intended to have. And they've been able to show that it has led to, in very specific communities, I want to be clear about this. This is not something that's national or statewide or even like a citywide. We're talking very micro level community where we've seen this happen. But there are certain communities that have completely adopted this model. And in those communities, it's led to lower rates of poverty, abuse, and neglect among children, while also seeing some incremental increase in housing stability in those earliest years of life. So since we've seen that in these very micro sessions, it's thought that if this was adopted widely, that we'd see a wider range of these impacts in a much larger geographic area, encompassing cities, maybe even counties or states. But I think we all know that there's many barriers that exist in various states, various jurisdictions but this is something that in the early childhood development field that they are continuing to advocate for, and we're talking about them adopting this 21 years ago. So I pull that example just to show that, yes, this kind of change and engaging with the future in this way can lead to really good outcomes if things are put in place correctly, but it takes a really long time to get everybody on board. Yeah, next slide, please. Let's see here. So another way of looking at change too, this is a way that I found to kind of engage with people in change, is the idea of legacy thinking. So this whole model that was adopted in the early childhood development field is a good example of that. So legacy thinking is the desire, the want to have a positive impact on future generations. And people that have that kind of desire, that is a lot of energy that can be harnessed to have effective policy change and advocate for effective policy change. And it also is a way of looking at it that makes it bigger than that person, because I've found, when you're going to policymakers and talking about, different changes, they don't necessarily want to hear about they're fine to hear about your individual role in that and how it impacts you and everything. That's powerful. But they also want to hear about how this is going to impact a larger community. So having people that are looking at this through the lens of of leaving a legacy behind, that is much more broad than just themselves. So kind of framing them in that way can be very helpful when advocating. And then one thing that I think people, that I've seen people kind of maybe miss the mark on a little bit over time is when they're advocating, they're emphasizing the problem, and all they're talking about is the problem. And the more you talk about the problem and you point out how big of a problem it is and things like that, people start to shut down because they start to think this problem, I can't do anything about it. I don't have any power to do anything about it. Even policymakers might think that it's just too big to deal with. So one way to deal with that is also not only emphasizing the problem, but really emphasizing the solution to it, because that's emphasizing what can be done. And then you're giving people kind of like marching orders, like, here's what you can do to impact this and get to this larger change. It might be something very small, but if you can connect that small act to this larger effort, then you can engage people more. And then it becomes less scary because you're not taking these giant, you're not taking off more than you can chew, basically. Sorry. And then, like I just said, many of these issues, they're huge. What we're trying to fix with policy change are just huge, daunting societal issues. But being more solutions-based is going to alleviate that apathy around these larger issues. And it allows you to take it in bits and pieces. Like I mentioned, change is rarely sweeping. And usually if there is sweeping change, it's not the kind of change we're looking for. So we have to think in incremental, we have to be in an incremental headspace, basically, when we're talking about this, because if you think that you're going to make this change real quickly, you're going to get beat down pretty quick, and then you're going to feel demoralized, feel like you're not reaching your goals, you're going to feel like you failed. So it's almost like maybe, if some people on here have experience writing grants and things like that, we always try to use like the SMART goals. It's kind of like looking at it in that way and being much more measured and specific and kind of clear-headed too, that this change isn't just going to happen. I think I think there's another slide right after this. Thank you. So one thing to keep in mind is that we want to always remain factual and share data and other supporting documentation to convey your status as a subject matter expert on whatever it is you're advocating for. So you have to show, yeah, I'm the person that knows about this topic. I'm the expert on it. However, we can't fully rely on, I'm the subject matter expert, and let me give you all these statistics and all this data and everything, and this is what's going to show you how bad this problem is. Look at all these numbers. The data, that helps because it's supporting, but what you need to do is, numbers are just numbers. And people have a really hard time of connecting those numbers to individuals and individual people's experience with that policy or that law or whatever it is. So you've got to be able to connect those numbers with the individuals. So such information is most powerful, like I said, when directly connected to a person and their experience specifically related to this policy change that you're advocating for. Personal experiences coupled with factual information and solutions-oriented approaches will get the best results because you're laying the groundwork with the data, and here's the environment that we're dealing with currently. And then you're saying, this is the problem, this is how we're going to fix it, and here's somebody who's dealt with it, and this is how this has impacted their life. All three of those aspects are what people are going to respond to. Hold on just a minute. Sorry, can you go back to that slide? My office is right on a very busy road, and there's a lot of ambulances that come by. Apologies for the background noise. So another thing that needs to be done, in addition to being factual, personal experiences, and being solutions-oriented, you also need to give the context of things as well. What is the larger context? And a lot of times when you're trying to give that context, you're trying to tie it back to that person that you're advocating for this policy change to. You have to show how what changes you're proposing or advocating for are going to impact the larger community. So there can be a lot of different ways of that where you have to appeal to them in a way. So when you're appealing to people, it might be something as simple as like appealing to their own personal sense of justice and connecting that with what's going on. I find that works a lot because most people do have a real sense of justice. And if you can tap into that with people, they can recognize whether they're an individual or they're a lawmaker or policymaker or whatever. If you can tap into that, then you're giving them almost like a permission structure to put themselves in other people's shoes and be a little bit more empathetic and understanding. And that might lead to some more change. I'm just going to give an example of this. So I had the experience of years ago partnering with a local doctor here in Cincinnati, Dr. Judith Feinberg. We both saw a need in the community for syringe service programs and syringe access back in 2007 when those programs weren't available in our area, and they pretty much weren't available throughout the state of Ohio except for in Cleveland. So we had both, through our jobs, I was a health educator that went out in the community. I went to a lot of substance use treatment facilities where I'd go and do education, then I'd go do testing. And for a long time, every month that I went to a particular place, everybody was there for alcohol, or there was a lot of crack and some other coke and, some other substances. But that was pretty much what we were seeing at that time. And then I remember just 1 month I went there 1 month and that was the case. And then the next month I went back, and like everybody I talked to through testing them or just the education, all of them were there for opiates and heroin and that. And that had been a complete shift in the drug use culture that we had seen locally. So that was what opened my eyes to it. So I started to advocate for it. And I vividly remember having a sit-down meeting with Dr. Judith Feinberg in 2007, and us both saying, we will have this program open by next year. It's going to be great. Well, the program didn't open until 2014, and instead of it taking a year or less to open, it took like 7 years for it to open legally. And I bring that up because it really illustrates how long it takes to have that change, because we went in there like, this is obvious. We're doing disease prevention. This will save money, those kinds of things. But the stuff that we heard back from people was more of like, well, how is this going to impact me? So we had to change our messaging a lot. And one really good example of that is when we were advocating for this, we did not see a community that we were advocating for being the police. We didn't think that was a community that we were advocating for when advocating for syringe exchange. But we quickly learned that we needed them on our side, and we needed them to buy into what we were doing. One of the ways that we did that was whenever they had at different precincts, like District 1 or District 5 or whatever, when they had shift changes, we would go there and do like a quick 10-minute talk about harm reduction and how to avoid getting needle sticks, and talking about how if we have a syringe exchange, you're less likely to come in contact with somebody through your work. Maybe you're arresting them or whatever you're doing. If you're patting them down, you're less likely to get exposure to a needle stick that way, because people aren't going to be having all these dirty needles. So we had to kind of change our messaging a little bit to make it speak to that group of people, because we weren't speaking to them and they were a stakeholder that we didn't think of before. So that's just one example. And I think I do remember when we did that, I felt kind of weird about it, because I felt like, well, this isn't really my role, or this isn't what we're really advocating for. But then I came around to it because it was like, well, they're stakeholders too. and we need them to get on the same page as us if this program is going to be successful. So that rolls into another thing that one also has to be open to when you're advocating for things. And that is the whole idea that you're going to be working with people that you didn't think you'd be working with, probably. You are going to be working with people who make policies, lawmakers, advocating for those things, who don't have the same views as you on a lot of different things. But the Venn diagram of what you're looking for and what they're looking for has an overlap somewhere. So you need to find where that overlap is and use that as a way to show, see, we agree on this. We might not agree on these other things, but on this thing we agree. Let's focus on this and let's move forward. That has been, when you're advocating for things, it is in surprising and strange ways that these Venn diagrams will overlap. A good example of that right now is I don't know if you can see, but I'm wearing my modernized HIV laws shirt from the Ohio Health Modernization, of which I'm a member, and there are a few people on the call too that are a member of that group as well. And that's a group that's advocating for policy change at the state level in Ohio to deal with the 6 different statutes that criminalize HIV in various ways. Well, there has been a representative, her name is Sarah Carruthers. She is a representative in the Ohio House, and she has introduced 2 bills. You can go to OhioModernizedNow.org. That link has also been shared in the chat earlier to find out some more information. But there's been 2 bills that have been introduced by Sarah Carruthers. One of them is Bill 498. You can also look this up on the State House's website. One of them is Bill 498, which would just completely do away with the knowingly donating blood while living with HIV is a felony in Ohio. But if I'm knowingly donating blood and I have hepatitis C, nothing happens. They just tell me, hey, you got hep C, you can't donate blood. But if I have HIV, it's a felony. So 498 gets rid of that. And that's all 498 deals with. Then she also introduced another bill called House Bill 513. And that bill is a much larger bill that basically kind of repeals all of them. So we'll see where all these go. They've been introduced. They're in the Criminal Justice Subcommittee currently. And OHMM is working on advocating for that and making these changes happen. Because it's an election year, especially a contentious presidential election year, they won't be having any meetings or hearings until after the November election, and they probably won't actually be back at the State House until November 12th. But that's a really good example of having someone who is on our side and wants to see these changes happen around the HIV laws. They want them modernized, they want them repealed, they want them gone. And Sarah Carruthers is a very right-wing Republican representative from Butler County, Ohio, which is one of the reddest counties in Ohio, I think. And when we started this process, I would have never thought that someone like her would have been the sponsor of the bill. But we met with her, we told her the story, we had a conversation, and she was very empathetic and sympathetic to what we were trying to do because of some personal experiences that she had. So I think that really illustrates you never know who has people that they love in their life who have HIV and are either still with us or maybe have passed away in the past. And that was a real thing. Her personal experiences is what got her to get onto our side. So I just say that because that only happened within this past year where we met with her and we got her to sponsor these bills and everything. And I'm still kind of surprised at how supportive she is of this. Yet when you look at things that she's voting on other topics, it doesn't, in my mind, jive there. But you got to take it where you can get it, and we're taking it from her. So with that, I'm going to ask if Zoe can stop sharing screen, and if her and Ariel can come back on camera, and we'll go through, we've got a couple questions in the Q&A, and we'll talk about that. If there are any other questions, please put them in there. Let's see. Zoe, do you have the Q&A pulled up?
Yes, I do. So the first question kind of focuses a little bit on my portion of the presentation. So somebody asked, what are some steps an individual can take if they are experiencing stigma and or bias from their healthcare provider? So I would say, for one thing, many healthcare institutions, many hospital systems do have strong non-discrimination protections, and most of the larger healthcare systems have patient advocates or an equivalent to that. So in those cases, that would be a fantastic opportunity to reach out to a patient advocate, an ethics committee, something along those lines, and report that healthcare provider to them and seek out from assistance from them. Also, I always tell folks, keep in mind, you can fire your doctor. You can always fire your doctor and find a new one. I know in rural areas, like I was saying earlier, that may be easier said than done. But that's, and I just see that Angela dropped in the chat that grievance policies also help. Most healthcare systems, well, I would say all healthcare systems, I believe, are required by, through their accreditation process, to have different grievance policies to report any issues.
And to Zoe's point, I'll just add that patients have the right to request a different provider if you feel that you need to for whatever reason.
Absolutely. Thanks, Ariel. So our next question is, can you speak into the importance of hiring people with lived experience / peer advocates?
I think we all probably have opinions on that, but it's a best practice, in my opinion. Especially in this field, a lot of what I have done over the years, I didn't learn in school. I didn't learn that when I went to college. It's comes from my lived experience coming into this field and the experience that I've had in it as well. So I think, it's imperative to have people who have lived experience, can be peers, can talk to people in that way. I would say here at Caracole, we try to be extremely diverse in our hiring practices, and in prevention, the department that all three of us are in, we especially try to be very intentional with who we're hiring for positions, because we want people to be able to work with people who use drugs, trans community, and maybe not just even a larger trans community, like a specific African-American sex worker trans community. We want to be able to connect with people. And a lot of times we're having kind of one-off conversations or one-off instances that aren't very long, don't give us a ton of time to build rapport and a relationship. But if you've got people who are of the community that they're serving, that some of that is kind of built in and helps. So I can't talk about that enough. I'm sure Zoe and Ariel.
Yes, and actually, going off of what Adam said, when you have someone who has lived experience working in the field, right, the communities that they are engaging with they're more likely to trust someone who shares their own lived experience versus someone who is, in regards to the Black trans community, versus someone who is white, straight, has a master's degree, a PhD, and going into an urban neighborhood in a suit and tie, right? They aren't going to trust that person, right? However, they are going to trust the dog who knows what it's like to have to do what you got to do to survive, right? And because of that, there is that dynamic of, you see me, I see you, I trust you, and so hiring people with lived experience, having people with lived experience is so important in the world of public health, specifically in our field.
I have one thing to add to that, though. We talk about the whole lived experience. We need that kind of thing. I started working in this field in 2007, and that is around the time that this field started to become more and more professionalized. And I'm not saying that that's like a bad thing, but that it will, what I've seen is the trajectory of we're going this way with professionalized. And then as that happens and we're going more and more professionalized, I hear more and more, we need more people with lived experience. Well, we used to have that before it got all professionalized in the way that it is now. So that there's got to be some kind of like middle here that we could find to better utilize individuals with lived experience, because it's a win-win for everybody. Like that might lead to employment for that person with lived experience, might lead to health insurance and other benefits like that. And then it's also going to benefit the the communities that they're trying to reach. So I just put that out there because it's a historical thing. And one thing that I had a note from when Zoe was talking before, you're on one of your slides, you had those 5 points about this is what you should be doing. And I think on that slide, the number 2 was come prepared and do your research. Totally agree that we have to do that. Just every time I see someone tell me that with what it is in regard to like medical care, I'm not a doctor. Like what, like I thought that was the whole point of having a medical system, was that they did that. But we unfortunately have a medical system that not everybody can trust. So it puts all this onus on the individual to have to do this, when it really should be their provider doing that. And that's why I'm, like they said before, I'm a huge believer in you can fire your provider. Like if you're not getting what you want from them, go somewhere else. Because you're going to find somebody else. You know, there are good doctors out there. There's really, my doctor is great. She's a nurse practitioner. That might be why she's great, because she's a nurse practitioner. But there are good providers out there. And if you don't have a good provider, unfortunately, you got to go find them.
Ariel and I both see the same doctor, and she's fantastic as well. So I come from a very unique perspective that I have been lucky enough to have nothing but wonderful experiences with the healthcare system, at least in my adulthood. When I was younger, I had some not great experiences. And unfortunately, that taught to me the importance of researching my conditions. That my pediatrician was not familiar with many mental health conditions. So that's where I learned that lesson myself. So let's see here. We do have somebody that just wants to, how would you recommend connecting with a peer advocate? And then I do see Michelle, I see that you have your hand up. As far as recommending with a peer advocate, many times in emergency departments, there are peer advocates present, especially for folks with lived experience of using drugs. Here at Caracole, we let our folks know about our peer support and peer advocate programs. And it's so the best way is to request a peer advocate, I would say. Do either one of you have anything to add to that?
Okay, not really.
All right.
I do want to say what Angela's comment in the chat. Yeah, I totally agree. Like that's part of the professionalization of it. What do you need an LISW, blah, 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 to do patient, benefits navigation or something? There are a lot of requirements on these grants and everything. And then you're right, even then when we get to the position that, sure, it's fine for someone with lived experience to be in that position, it pays like nothing. So it's a real problem. I'm just, I think there's got to be a middle part that we can find to better utilize and take care of people with lived experiences, while still remaining professional and providing good services. I mean, I think it would only enhance the services if we had more people with lived experience working in this field at all levels.
And I think that part of that may be having entities meet folks who have lived experience halfway, because if you're coming into a public health position and you don't have any experience with this system or this protocol or what have you, right? This may mean that, oh, okay, you need to sit down with this person and talk about how this works, talk about how that works. and really like meeting folks realistically halfway and addressing things that they may not have any familiarity with, and that is okay.
Thank you, Ariel. Well, it looks like we've gotten through all the questions. It is after 1 o'clock. So I'd like to thank everybody. Thank you for attending this week.